Hello and welcome to this presentation entitled Individuals with Mental Illness and Lived Experience of Using Methamphetamine, Considerations for Harm Reduction Strategies in Hospital Settings. This project is being conducted by Dr. Cheryl Forchuk, Dr. Michael Silverman, Dr. Kelly Anderson, and Dr. Abraham Rudnick. My name is John Serrato and I am the coordinator for this project. So methamphetamine use is on the increase in Canada. A study conducted last year found that daily use of methamphetamine increased from 1% to 12%. As well, the prevalence of methamphetamine use in the previous 6 months within the project or the study found an increase of 19 to 36%, so almost doubling. Individuals who use substances often have coexisting mental health conditions. It's well established that there are strong associations between addiction and mental illness. So how can we help people who are experiencing this? Well, one potential strategy could be harm reduction. The Canadian Mental Health Association defines this as an evidence-based, client-centered approach with a focus on reducing physical and social harms through the provision of choice without abstaining. This means that patients should be given the choice of how to address their addiction or receive support without having to go through withdrawal, without having to go cold turkey, and trying to maintain abstinence. So what are the aims of this project? Well, one of the aims is to potentially improve hospital care through that provision of harm reduction. In doing so, we may be able to promote patients' involvement in their care. As Cheryl will talk about in a moment, situations such as going through withdrawal whilst waiting in a waiting room can be a very difficult experience for people with addiction. And this leads to people discharging against medical advice, leaving the hospital. So really, we want to keep patients involved in their care and engaged with their care team. In doing so, we can meet patients' needs and reduce adverse health outcomes. As I was saying, people leaving the hospital, not getting the care they need, not receiving the treatment they need, can cause their health condition to worsen. So this project is a 4-year project. Currently, we are in year 2, and right now we are looking into what harm reduction strategies we can develop, what can be implemented. In the previous year, we interviewed a large number of participants, as well as healthcare service providers, to get their feedback, their recommendations, their suggestions on what should be changed, what should not be changed, what they would recommend, what they would not recommend, and so forth. Years 3 and 4, we will also be interviewing large numbers of participants and healthcare service providers, but this will be more of an evaluative feedback approach for people who have been exposed to the new strategies or interventions to get their feedback and how we can make changes in the future. So the sample, the inclusion criteria, participants had to be aged between 16 and 85 years old. Participants with past experience or current use of methamphetamine was required. As well, we included people who were recovered. They were eligible as well, as they did have past lived experience. And also, participants had to have received any type of service from any hospital. A total of 114 participants completed the interview. So the procedure, we did individual interviews. These were conducted in person whilst following strict safety protocols, as you can imagine. This included physical distancing, the use of PPE, hand sanitizer, and following the rules on site wherever we were. Alternatively, we also did interviews via telephone. We included a large number of outcome measures. These included a demographics questionnaire, 2 questionnaires on substance use. These were the Treatment Outcome Profile, also known as the TOP, and the GAIN SPS. As well, we asked questions regarding community integration, service use, quality of life, and health through the short form 36. So analysing this data, we'll be using an evaluation plan that uses a standardised framework. This framework is broken down into 4 sections, as you can see from the diagram. So the first one is effectiveness. Were the interventions effective? Did they work? Did they produce positive client outcomes? Economic. The economic analysis looked at the cost savings compared to usual care. Is this cost effective? Ethical analyses also included looking at, was there autonomy for the participant or the population under study? Was privacy observed? Was there any benefit to the individual from the project or from the intervention? And lastly, we have a policy analysis. What are the policy implications? How can we inform policy? How can we inform decision makers? So this approach, we looked at very broad, covered a large number of areas that could have significant impact in the future. As you can see, the majority of the sample was male, with 75, 37 female, and 2 identified as non-binary. The mean age was 35.5, roughly, and 16 participants identified as LGBTQ2+. As you can see, the majority of participants identified as Caucasian. The second largest group was Indigenous, and there were 7 participants who identified as mixed race, specifically Indigenous and Caucasian. So one of the questions we asked on the demographics questionnaire was mental health diagnoses. As you can see, there's a lot of overlap. 63 participants identified as having or reported having multiple psychiatric diagnoses, and 29 identified as only having one. The most common, as you can see, was mood disorder, so depression and bipolar disorder. More than half identified as having that diagnosis. 57 closely followed for anxiety disorder, and then disorder of childhood, so that included ADHD, substance disorder, and psychotic disorder, very close together, 28, 23, and 21 respectively. So a large number of diagnoses within this sample. So usage in the hospitals, this was quite significant. So 66 participants reported a psychiatric hospitalization. 31 of those 66 reported that they did use a substance whilst hospitalized, so they were using in the hospital. Of that 31, 19 used methamphetamine in the hospital. On the physical and medical wards, 88 participants reported being hospitalized for a physical or medical condition. Of that 88, 35 reported that they secretly used substances in the hospital setting, and of that 35, 15 used methamphetamine. In terms of the reason for being hospitalized, 35 participants reported that the use of methamphetamine directly caused a psychiatric hospitalization. Largely, this was delusional behavior, psychosis, paranoia, and aggression. And as well, 39 participants reported that methamphetamine directly caused a physical or medical hospitalization. So it just outlines the dangers of using methamphetamine and the effects it can have on a person. As you can see from this graph, the majority of participants were experiencing homelessness, a total of 58 of the 114. And the second highest category was living alone, which was 26. As you can see on the side, there were smaller numbers for each of the other categories. Very poignantly was the fact that 112 of the 114 participants had experienced homelessness in their lifetime. Only 2, therefore, did not experience homelessness in their lifetime. And homelessness is very closely linked to mental health and addiction. People with mental health are more susceptible to homelessness. This may be because of the lack of capacity to sustain employment, little income. Especially with mental health, they may become withdrawn from friends and family. So this loss of support leaves them with fewer coping strategies. And this, of course, means that unhealthy coping, such as substance use, therefore becomes prevalent. So in terms of service usage, 62 people visited the emergency room, and for a total of 187 visits. So that's roughly 3 visits per person in the past 6 months. As well, 45 of those 62 participants required an ambulance, and in total there were 106 ambulance trips. Visiting a service provider, such as a doctor, nurse, social worker, housing worker, roughly half, so 51 individuals went and visited a service provider, and this equals 223 visits, so roughly 4 visits per person. Talked on the phone with a service provider, we're expecting this to be, fairly high given the current pandemic, but only 38. Again, this may have been because a lot of the participants were experiencing homelessness and may not have had access to a phone. And only 40 accessed a safe consumption site, which is surprisingly low. So in discussion, there was a high prevalence of mental illness. There was a high prevalence of homelessness. Again, these two facets are often linked in the research. Methamphetamine use does occur in hospital settings. As much as we don't think it does, or think it may not happen, unfortunately it does, it's just that we don't know about it. Or that patients just don't want to divulge that information, they're not comfortable telling somebody, particularly as current policy right now is more focused on abstinence as opposed to usage, so that can cause conflict and can cause patients to use secretly in the hospital. And Cheryl's going to talk about that in more detail in a moment. So can harm reduction strategies help? Well, what was suggested and where do we start? And Cheryl Fortruck is going to discuss this next in more detail. So I thank you for joining us today. If you have any questions, please type them in the little box to the side here, or maybe it's that way, I'm not sure. But feel free to ask any questions you may have. Thank you for watching, and thank you for listening.
Thank you for joining us today. Right now, I'll present the qualitative findings from the same study that John just went over in terms of talking about people with a lived experience of methamphetamine use and healthcare providers. How can we inform hospital care and harm reduction? I'm Cheryl Fortruck, but as you can see, we have other members of the research team listed here. Again, going into the background, as mentioned, we know that people who use injectable substances in hospitals, such as methamphetamine, are at greater risk of infection compared to being in the community, that the harm reduction strategies for methamphetamine that are commonly used in the community are not implemented in hospital, and that we know that generally harm reduction is considered to be a best practice. It reduces the negative effects of health behaviors. It's more cost effective, improves clinical outcomes, and increases enrollment to detox. It essentially helps people on their road to recovery. So what we did for the qualitative analysis is basically we had various things audio taped. When we did the individual interviews with people who used methamphetamine and had access hospital services, or whether it was the virtual focus groups, in either case, these were recorded, transcribed verbatim, and we used a thematic ethnographic method of analysis. So based on these findings, we had suggestions for harm reduction, but also we had issues related to addressing stigma. And when you look at this list, you'll see a number of different harm reduction strategies, but it's very important to understand that people said they would not actually engage in any of these opportunities if stigma was not first addressed. So the strategies that people were interested in was having a safe consumption site available if they were hospitalized. And there was different discussion about what that would look like. Sometimes it would be a matter that they would prefer just to have somebody monitor their use while they're in hospital, or in some cases they're talking about a specific safe space. The idea of having sterile needles or syringes available as they are in the community, people thought was particularly important because they described otherwise when in hospital, they may end up having to reuse what little supply they happen to have available. That having a safe substance supply would also be useful. The sharp boxes, issue was actually a surprise to a lot of us. It was first identified in the patient data that many people talked about this issue of when they're in hospital, that there would be no sharp boxes. The sharp boxes would be removed. And that, as you heard from the quantitative data, people did continue to use while they were in hospital. So now how do they safely dispose of the needles when there's no sharp boxes that are available to them? And people actually talked about this being somewhat of a moral dilemma, giving them some moral angst, actually, because they ended up having to unsafely dispose of the needles. And many people said that's not something they would normally do, but they were essentially given no choice. Most often that meant it went in the garbage, maybe covered with paper towels, whatever. But in some situations where they were unable to get out of bed, then it meant that it was actually hidden in the bed linens. In either case, it really puts staff at high risk of being accidentally getting a pinprick from those needles. And again, these are people who are generally in hospital, often due to bloodborne infections. People also talked about the idea of withdrawal and having appropriate means of detoxing while in hospital as another potential form of harm reduction. So if people are not supposed to be using in hospital and they have an addiction, staff have to be prepared to support them in that detoxification process. So also discussion around medication, whether that is to assist with either the detox, cravings, or other issues. Now, going back to that issue of stigma, a lot of that really was related to the issue of stereotypes around people who use substances, but also lack of knowledge about what an addiction actually is. Like the very idea that by simply having a rule, you're not supposed to use substances while you're here, for someone who has an ongoing addiction is simply not realistic. If an addiction would be cured by just saying don't use it here, we wouldn't have addiction problems. It's simply not. It's just not that simple. People describe the problems that having no harm reduction causes. Essentially, no harm reduction means harm. If you're not reducing harm, you're letting harm exist. There was also a number of barriers and facilitators identified by the healthcare providers that we'll get into in more detail. So this flow here summarizes what happens with the current situation. And what we see is, if you look at this idea, is people, both patients and staff, talked about how the situation interferes or impacts the communication, the interactions. So if you look at the red, this is kind of the current state that how patients are perceiving the situation. They perceive that there's stigma and a lack of knowledge in relation to addiction and withdrawal. Because of that, they experience a lack of trust, but really it also comes through from the staff groups that it's mutually a lack of trust. The staff don't trust the patient and the patient doesn't trust the staff. Because of that, there's reduced help-seeking engagement, and that, of course, leads to negative consequences. The preferred state is to address stigma and acknowledge dealing with this knowledge gap through staff education, with the hope that that will actually increase mutual trust, that people would be more that would improve help-seeking behavior and engagement. Actual harm reduction could occur, and then there would be a reduction in harm, essentially, a reduction in the negative consequences. I'm just going to very briefly go over the issue of stigma, since we've heard a lot about it, but the core of this is that substance use is perceived as a moral and personal choice. And because it's a choice, you could decide today or tomorrow to do something different, rather than recognizing it as any kind of illness or health issue. And that when people talked about stigma, they found it was often intertwined with other things, such as their income, their housing, as well as the substance use. And again, there's a couple of quotes here to exemplify it. One from one of the people with lived experience. I don't know how to answer that one either, personally, right now. And until people and doctors and the systems change their attitude towards us, nothing's going to change. A staff member said, I would say it's unfamiliar territory for a lot of us, and that's where a lot of that stigma comes from. So there's consequences to not having harm reduction. And again, if no harm reduction means harm, is the essence of it. And what people talked about, whether it was staff, whether it was the patients, people are left in a no-win situation. For patients who access hospital services where there's no harm reduction, there's essentially three choices that they have. In the middle, they could go with the hospital rule, don't use, but then they're going to go into withdrawal. And if they go into withdrawal, there can be serious consequences, particularly if the staff is unprepared to meet that. And some of those consequences include the risk of death, the lack of stability. There could be behavior issues. So if we're insisting that people not use, we have to be able to deal with the withdrawal symptoms. So the patients have that one choice: follow the rule, deal with the withdrawal. Another choice people make is to either leave early or avoid altogether. In other words, don't even seek treatment, or once the withdrawal starts, leave at that point. This also leads to poor health outcomes, and also can increase the risk of death, because there was probably a reason they were in hospital in the first place. Which is now not going to be addressed. Their health may then get worse once they're out and there's a risk of readmission. Their other option, if they don't avoid the hospital altogether and don't go into withdrawal, is to hide their use. Again, that also has consequences because there isn't the structures in place, the clean supplies, etc. So that will lead to other potential issues, as you can see, including this risk of a secondary infection, a hospital-acquired infection, for doing things like using tap water instead of sterile water, for having to reuse needles. So no matter which of these three choices a patient makes, there are going to be risks related to their health. Like there's really, without harm reduction strategies, there's no good choice that will not compromise their health. The staff, unfortunately, are in a similar catch-22 or no-win situation. So the hospital policies generally are about zero tolerance for substance use. So if the staff go along with that, zero tolerance, that perpetuates the stigma, and there's no need to deal with one's personal knowledge. All you have to do is enforce the zero tolerance. On the other hand, if they accept the literature that harm reduction is indeed a best practice, and want to look at that, they actually can't implement that because of policies, practices, the whole legal framework at the hospital. So they, no matter what they do, they are going to be caught in a spot of frustration and ineffectual care, because it doesn't matter if they accept the principles of harm reduction if they can't implement them. And if they don't even accept them and simply accept the zero tolerance, again, that goes to all those negative patient outcomes. So again, you see a couple examples of quotes. So that's why a lot of us leave the hospital, like, sign ourselves out earlier, just walk out, because we're sitting there and withdrawing. And plus we're in all that pain from why we're there. And they really just don't give a shit, because it's like from drug use. With staff, is they come in here with the expectation that they have to hide it. So it's a no-win situation for anyone to hide this issue of the lack of harm reduction. In the interest of time, I'll go through this fairly quickly, but again, there are many barriers and facilitators to have harm reduction in hospital. We talked about the barriers like the stigma and lack of acceptance. There's also cost issues around time, space, availability. That the idea of trust has to be addressed. There's policy and liability issues from a very pragmatic perspective. And some of these policies are actually legislatively framed in terms of any safe consumption site needs an exemption from Health Canada so that people aren't charged for using substances. That we have the things such as the Public Hospitals Act. So there's many pragmatics that would need to be dealt with. And then lots of issues around harm and safety either way. And really that harm and safety, includes issues that both staff and patients can be impacted by. And again, some examples along the side there, as well as the quotes. And again, most of these quotes come from the staff. So really trying to convince them is not the right word, but educate them so that they understand why it's important, I think is really, really key. Another staff, in order for staff to be on board, leaders have to be on board. And another staff quote, if you're going to do harm reduction, I think you just really have to look at the whole picture from admission to discharge to transition to the community. Oops. Sorry. So for the discussion, we've heard a lot about stigma, the need for education. We've looked at the fact that not having harm reduction has a very serious negative impact on therapeutic interactions and communications, that we need greater flexibility and involvement for patients, that we do have to address the policy implications. This is not something that can be easily done. There's a number of policies. And as I said, it involves things such as exemptions that need to be addressed. But it's important to make this journey to reduce the negative health consequences that we currently see for patients, as well as the ethical dilemmas that it puts staff in, staff who are aware of best practice and also aware in some cases that they're unable to implement those best practices. So this is the time for questions. So thank you again for watching and listening.
Hi everyone, my name is Dr. Jessica Ryman and I'm an epidemiologist at the Middlesex London Health Unit. I'm very excited to be here today with Dr. Alex Summers, our Associate Medical Officer of Health, to share with you some of the work that we've been doing. The title of our presentation today is The Implementation of a Local Surveillance System for Fatal and Non-Fatal Impacts Associated with Crystal Methamphetamine Use. So just want to give a brief outline before we get into it. So we're just going to start with some quick acknowledgements, a brief background, an overview of the surveillance dashboard development process, and then I'll go into a bit more detail about some of the steps there. So the environmental and literature scans, our community consultations, and then I'll take you through our finalized indicators and actually show you our finalized surveillance dashboard, which is available on our website. And then we'll move on to a few lessons learned, some limitations, and some of our next steps. So before we get started, I just wanted to take a moment to acknowledge the many partners who took part in this initiative. Although Dr. Summers and I are presenting this work, it was certainly a collaborative effort. First, we'd like to acknowledge FACT's Substance-Related Harms Division for funding. This project wouldn't have been possible without the input and feedback from our community partners who work with those who use crystal methamphetamine and other drugs. Additionally, I'd like to thank our internal project team at MLHU for their support and expertise related to this project. So in Middlesex, London, community and stakeholder reports have suggested that crystal methamphetamine use appears to be increasing and impacting our community to a greater degree than in other regions across Ontario. Just to back that up a bit, from 2018 to 2020, methamphetamine toxicity death rates in Middlesex, London more than tripled, and the death rate in Middlesex, London was significantly higher than the rate across the rest of Ontario. The negative impacts associated with methamphetamine use extend beyond the individual to affect the community, and we know this is a big problem. So the creation and dissemination of a methamphetamine surveillance dashboard fills a gap in surveillance data needed to support a fulsome and coordinated community response to address methamphetamine use. So here we have a quick overview of all the steps taken in the development of our dashboard. Unfortunately, I don't have time today to go through every single step, but just wanted to give you a high-level overview of the steps we took to get us to the finalized surveillance dashboard. I will go into a bit more detail, as I mentioned before, so we're going to start with the environmental scan. And the purpose of the scan was to identify programs and services related to methamphetamine use and also to identify data being collected related to methamphetamine use and harms in the Middlesex London region. So to do this, we conducted an online survey of our community partner organizations who are members of the Middlesex London Community Drug and Alcohol Strategy Group. And we started with that group because we already had connections to them. Half of those organizations responded, which was great. And they all identified that they provide programs and services, and they also collect data related to methamphetamine use in Middlesex, London. So kind of at the same time, we also did a literature scan. The purpose of the scan was to identify and assess appropriate population health indicators of methamphetamine use. We included both peer-reviewed and gray literature. The terms we used included methamphetamine indicator, surveillance, and statistics. We did have some inclusion criteria. We wanted studies that were published in English. We did limit the date range from 2018 onward, and that was because we know the substance use landscape is constantly changing, and we wanted to have the most current and relevant studies and indicators possible. The last inclusion criteria was that the studies must have included information or examples of indicators to track methamphetamine use. In the end, we included 29 peer-reviewed and 10 gray literature articles in the scan. Categories of some of those commonly identified indicators related to methamphetamine use included self-reported use, wastewater-based epidemiology, driving under the influence, police data, fatalities, and healthcare utilization. Indicators collected from the literature scan were compared to the data available from community partners, which we had gathered in the environmental scan. And we use these to establish local population health indicators of both fatal and non-fatal harms related to methamphetamine use. So then we moved on to more in-depth community consultations, and the purpose was to engage our community partners who provide programs and services to clients who use crystal methamphetamine and other drugs. And we wanted to include them throughout the entire project, starting with the initiation, through the development, and the launch stages of the project. We asked our community partners for a lot of things, but some of the key questions and key feedback we wanted were around the candidate list of indicators. We asked if they had any additional indicators that they would suggest we include, and if they knew of any data sources that we could use for these indicators. We also asked our community partners to connect us with additional organizations who might be interested in this project or who might have data to share. And then finally, we asked them to provide feedback on the methamphetamine surveillance dashboard, including the language that we used. Our community partners shared positive impressions of the finalized methamphetamine dashboard. They said it was readable, inclusive, and very easy to navigate. I will say that community consultations were likely the most important component of the creation and dissemination of the methamphetamine surveillance dashboard. So our candidate list of population health indicators underwent assessment by both the project team and community partners. Indicators were removed or added based on data availability, assessment of the data, and other feedback. 5 categories of indicators are presented on the surveillance dashboard, and these are based on those indicators, which we already discussed. And these 5 categories include harm reduction service utilization, healthcare utilization, treatment service utilization, outcomes and fatalities, and crimination related to methamphetamine. So these are all on their own page on the dashboard, and an additional 6th page has been included to provide technical notes about the data. Comparisons are provided between Middlesex London and the rest of Ontario where possible. We've attempted to use language on the methamphetamine surveillance dashboard that is non-stigmatizing because we know people who use substances experience stigma. So we asked our community partners to really focus on this and make sure that from their perspective, we weren't using any stigmatizing language. So the dashboard is available on our website, and this is the URL to get there, but I am going to open it up actually for us in a minute here. So this is what the landing page looks like when you go to that URL. And the methamphetamine dashboard is located within the Community Health Status Resource, or the CHSR, on our website. The CHSR is used as a repository for a variety of local public health data. Including the methamphetamine dashboard on the CHSR aligns well with our organizational strategic vision to have a single source of data for our community partners. So I'm just going to take a second here to open it up. So when you open up the dashboard, this is what it actually looks like. And as I mentioned, this is live on our website right now. So a couple things to point out for you. There's a last updated date at the top here. And right now it says October 2021, because some of the data has been updated this month. I will note that not all the data is updated at the same time. Some data is updated monthly, some quarterly, and some annually. And when the data is updated really depends on when we get that data from either our community partners or from other sources. These rectangles here are actually buttons, and they refer to the different pages on the dashboard, and they're broken down by the indicator category, as I mentioned. So again, you can use these to navigate and click through the different pages. So every single page is set up very similarly. So if you go down below the buttons, which are present on every single page, you see a brief description of where the data on that page comes from. And then some key points which describe a little bit about what we're seeing in the data below, just a little bit of interpretation. And then below that, there's a most recent data summary box. And this is to give a snapshot in time of what the most recent data we have for this specific page of the dashboard. So I'll use this page as an example. Here we're seeing the occasions of service where methamphetamine was identified by individuals at our safe injection site. So you can see here the most recent data I have is from August 2021, and we're showing both the number and percent of occasions of service where methamphetamine was identified. And then on the right here, we show the percent change in the number of occasions where meth was identified. And this squiggly line shows the trend over the past 6 months. And if you hover here, you can see the actual percent change come up as a number. And then again, this is the most recent data. So from July to August 2021, there was a 3% increase in the number of occasions of service where methamphetamine was identified. So if someone's looking for a really quick snapshot to see what's happening in our community with the most recent data, they could just come to this box on each page. If we scroll down, you can see the data from this box is all actually on this graph, and it shows you as much of the historical data as we have access to. And again, you can hover over the bars. So these bars are the number of visits where methamphetamines were identified, and then the line shows the percent of visits where methamphetamine was identified. Again, you can hover over, see all the data, and see the trends as well. And then there's some additional data on this page at the bottom. Again, the pages are a little bit different based on the data source, but it is important to note that they're all laid out the same. And I'm going to just switch to one other page just to show the difference here. So this data is from PHO, but the most recent data summary is a little bit different here. We have a little bit more information. It's just broken down differently. But then you scroll down and you see that there are additional graphs below. So we'll now move on to some lessons learned. The development and implementation of this surveillance system would not have been possible without the feedback, input, and data sharing of our community partners. As I previously mentioned, this project would not have been possible without them. This initiative fills a gap in surveillance data needed to support a fulsome and coordinated community response to address methamphetamine use. And when the methamphetamine data is combined with other indicators, it allows for the identification and prioritization of community issues that can be addressed by both public health and community action. The data presented on the dashboard confirms that crystal methamphetamine is a present and emerging issue in the Middlesex London region. This dashboard will be used to track and surveil the impacts of crystal methamphetamine use and will play an important role in identifying and prioritizing potential areas for intervention. So we did experience some limitations while undertaking this project. So although many potential indicators were identified to represent the availability, use, and harms associated with methamphetamines, many data sources were unavailable. This might also be related to the stigma experienced by those who use methamphetamine, which could lead to underreporting. So one way to combat the lack of available data and the underreporting associated with methamphetamine use could be through wastewater-based epidemiology methods to estimate prevalence of methamphetamine use. So this is just one idea that we have been considering. And then finally, during the COVID pandemic, much of the work of our community partners was altered, often increasing their workload. This made follow-up with some community partners difficult or impossible. So some next steps for us. Although this methamphetamine surveillance system was created for one public health unit region, it provides a model which can be applied to other jurisdictions. It will be important to share our findings more widely with the public health community and others so they can apply our learnings to their own surveillance dashboard development. We want to understand trends in the impacts of methamphetamine use on the community from the data included on the dashboard, especially in the context of the COVID-19 pandemic. Although some of the methamphetamine data included on the dashboard shows decreases during the pandemic, others increased, including rates of methamphetamine toxicity deaths. These increased in 2020 compared to previous years, which especially highlights the need for this surveillance in conjunction with opioid surveillance. We want to continue to promote the use of the methamphetamine dashboard and continue to collaborate with our partners to enhance issue identification and prioritization to inform community response. And finally, we want to advocate for the systematic collection of data at the regional and provincial levels to address data gaps identified through this project. So that's a quick overview of what we've been doing, and Dr. Summers and I would be happy to answer any questions you might have. I've also included my email address there as well in case you have any additional questions, but thank you so much.